The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Dr. Sean Eek's primary interests include the development, implementation, and evaluation of psychosocial treatment methodologies to improve the care of people with schizophrenia and related disorders. These webinars are made possible through generous donor support, including a grant from Local 25 Boston Teamsters. If you'd like to contribute, please visit our website at autism.com.
Thank you so much for that introduction. Thank you for joining us for this webinar today. My name is Sean Eek. I'm going to be talking about new work we've been doing in cognitive enhancement therapy for adults with autism spectrum disorder. To begin, I have no current financial conflicts of interest, although I have received grant support from a variety of sources, including the Autism Research Institute, for which we're very grateful. I'd like to begin this talk by reminding the audience, I've received a question about this not long ago, and I think it's important that we all remember that while autism begins in childhood, it does not end in childhood. Here is a prevalence graph of autism across from late teens all the way up to 100 in a very large prevalence study of individuals in the United Kingdom. And what you can see here is that the current rates of autism in childhood are roughly 1 in 59 children are affected. And you can see that the adult rates are not so dissimilar from that. 1 in 102 adults are also affected. And while the number of adults affected steadily decreases over time because of mortality, it's particularly important to remember that after an individual emerges from childhood and into adulthood and who has autism, that this condition does not go away, and that there are in fact supports that are needed to continue to help individuals succeed in adulthood and manage their condition throughout their lifespan. We know exceedingly little about outcomes in adults with autism. Much of the work in the scientific community and other communities have focused largely on childhood for important and significant reasons. Although the more we learn about adults, the more we're beginning to realize that few individuals have as good outcome as we might expect, or perhaps we might hope for these individuals. There is variability. These figures show a very large review study of some 800 adults with autism examining their outcomes. And as you can see, we didn't know a whole lot about them. Broadly, they could only categorize their outcomes as to being whether they were good, fair, or poor. Sadly, the majority of individuals were classified as having a poor outcome, demonstrated considerable disability in adulthood due to autism, although it's also important to remember that outcome was highly variable as well. Some exhibited fair outcome, some exhibited relatively good outcomes. Far too many, though, experienced a poor outcome in adulthood, and really suggests a need for additional and greater supports for adults living with this condition. Now, when we think about what is good, fair, and poor outcomes, those are often hard to understand and often hard to kind of get your head around. I think this work by Patricia Hallen illustrates the challenges in adulthood quite nicely. Patricia Hallen, also in the UK, has been following adults with autism for decades, individuals that were initially diagnosed in childhood. She's then followed them throughout their lifespan. This is one of her follow-up studies of 20-year outcomes of these individuals. And it's a smaller sample. It's some 60 individuals. They were all considered, quote-unquote, higher functioning when they were first diagnosed. But you can see 20 years later, after their diagnosis, the outcomes of these individuals still suggest significant concerns and ongoing disability. When you consider friends and acquaintances, 2/3 of the sample had never had any real long-lasting peer relationships involving reciprocity, selectivity, and sharing. When we think about particularly close relationships, really 3/4 of the sample had never had a lasting relationship greater than a month. Few had ever been married, et cetera, et cetera. And when you look at work life, These are all major domains in functioning in adulthood. When you look at work life, you'll also see that about over half of the individuals, just slightly over the half of the individuals she followed, had never worked or had been unemployed for long term, generally over a decade. And those individuals who were working were also working oftentimes in positions that they were overqualified for and were considerably underemployed, suggesting that when individuals talk about adults struggling with autism and struggling in adult life with autism, these are some of the characteristics that come to mind and that often describe individuals as they're struggling with this condition in adulthood. Difficulties maintaining friendships, difficulties building a career, finishing school, and so on and so forth. We would characterize most of these outcomes as, in fact, quite poor. Much of the sample here has been highly disabled, and this is despite being quote-unquote higher functioning at the beginning of their study and when they were initially diagnosed. In addition, we know not only a little bit about adult outcomes in autism, but we also know something about the costs of caring for adults with this condition. This is a study that was published very recently in Autism in Adulthood, comparing the healthcare expenditures between individuals with autism, individuals with attention deficit hyperactivity disorder, and then healthy individuals or quote-unquote controls. And what you can see here is that across all ages, from 18 all the way up to 50, ASD is the most costly compared to ADHD and compared to healthy individuals that do not have autism spectrum disorder. We spend more money on adults with autism than we do some of these other major conditions that are really disabling and infect children and adults alike. Unfortunately, despite the greater expenditures that have been invested and resources allocated to adults with autism, the outcomes remain relatively poor. If you think about just mortality rates, you'll see on the blue line are individuals without autism, and on the solid black curve, you'll see individuals with autism. And at about the age 20, these two groups really start to separate in terms of how long their lives are going to last, and that there's a tremendous amount of premature mortality in adults with autism, despite spending so much additional money on healthcare in support of these individuals. It makes one wonder whether or not that investment has really made a difference and has really been enough to change these different outcome trajectories for adults with autism. So what contributes to these problems? Autism continues to exist in adulthood. Adults with autism don't always experience disability, but oftentimes do. And the costs of their care are exceedingly high and result in relatively poor outcomes, suggesting an ineffective system for helping support adults manage autism and contribute to our society. There are a variety of factors that contribute to these outcomes. Perhaps the most important factor is what's known as the autism cliff. This is the fact that if you are under the age of 18, or in some cases 21, you are provided a litany of services from special education to special schooling, other types of clinical services, wraparound services for young children with autism. For most individuals at the end of 18 or the end of 21, these services often stop, and often in their entirety. Many family members and parents who are caring for young children with autism, as those children grow up and become older, express considerable concern and dislike for the fact that all the supports that were there for their child during this critical time when she or he is becoming an adult begin to erode. And individuals really feel as though they're falling off a cliff in terms of the supports that are available to them. This cliff exists for a reason, though. It's not entirely due to social forces or political forces. A lot of this cliff is due to scientific forces that have contributed to a real understanding or lack of understanding of adults with autism. Here you'll see graphs of articles published in PubMed over the years since the 1950s. And the blue lines you'll see are all the papers on autism, and the red lines are all the papers on adult autism. And you can see in the 2000s there was a dramatic spike in scientific studies and clinical trials and other research to understand and to treat autism. And you can see that that spike is nowhere near parallel when we consider adult autism. In fact, although there has been an uptick in recent years, it is dwarfed by the amount of information that we know about children. And so we really do not know nearly enough and do not know as much as we should about how to help adults, particularly when it comes to treatment. We know quite a bit about how to help children with autism in terms of early intervention and prevention programs, which are very important and absolutely necessary. As this condition continues in adulthood, it's equally as important and necessary to understand and learn about what best supports an adult who's struggling with this condition to become a contributing member of society, to be able to be part of a community, to build a good quality of life. Recently, about 5 years ago, my team and I conducted a review of all the behavioral interventions that existed for adults with autism spectrum disorder. Lauren Bishop Fitzpatrick, who's assistant professor at University of Wisconsin-Madison, led this review article. And what we found is striking, particularly because I could fit it all on one slide. There, in fact, had been, since 1965, only 14 published articles of behavioral interventions and how effective they were in terms of supporting adults with autism. About a quarter of these articles were limited to one participant, indicating a relatively immature evidence base in this area and the need for a lot more research and understanding into what types of interventions and programs and services could be most helpful for adults with autism. We know slightly more about how to help adolescents, although what we know is still exceedingly too little. Here is a graph that shows the number of treatment studies that have been published across the lifespan, and this hardly spans the lifespan. There are none past 22 by and large, so we know very, very little about how to support older adults with autism. And there are also very few studies about how to support very early intervention programs with very young children. Most of what we do know about how to help individuals with autism is about how to help toddlers and preteens, where you can see the most of the studies have been published. As you get to adolescents, 12 to 14, 15 to 18, that dramatically falls off. And then as you get beyond 18, we know exceedingly little about how to help adults. Important point about this graph and these figures is they're separated into two categories. The first category is represented by light gray. The second category is represented by dark gray. As you can see, we have many more studies that are light gray than we have that are dark gray. And those studies that are in the light gray hatching or shading are those studies that include a single case design, that is, just one participant. And so even in adolescents, pre-adolescents, and in toddlers, much of the evidence base is on one individual, which is not sufficient to change policy, to attract the attention of payers and funders, and nor is it sufficient to tell us how best to help individuals with these conditions. You need multiple individuals in a study. You need studies of more than just one people to try to understand generalizability. And you really need studies of group designs so you can get a sense of how one treatment compares to another approach to treatment, and then be able to make your selection on what would be the best for the individual. So we know exceedingly little about how to help adults with autism. We know some about children. We're starting to learn more about adolescents. We know very, very little about adults and older adults. And so why a cognitive enhancement therapy for adults with autism? Well, the work that we've been doing here at the University of Pittsburgh, particularly that which has been led by Marcel Just and Nancy Minshew, has indicated really over the last 20 years that autism is a condition that affects the brain in so many different ways. Of course, the field is still discovering all those ways that autism does affect the brain, both in childhood and in adulthood. But what we've increasingly come to recognize and realize is that this is a neurological condition that affects the way the brain communicates with itself, particularly over long-range communication networks, such as between the front of the brain and the middle of the brain. And we know that individuals with autism, the way this condition affects the brain is it makes it less likely for them to be able to integrate information and be able to process information that requires the use of multiple systems and complex mental operations. Not surprisingly, given the impact of this condition on the brain in individuals with autism and adults with autism, it's unsurprising that there is profound and a large array of cognitive challenges associated with this condition. Of course, some individuals display really dramatic and remarkable cognitive gifts with autism, the ability to think very abstractly, the ability to count and calculate on the fly, things that most individuals would not be able to do. And those are strengths that we need to not forget about, and as they are very important to build on. In addition to those strengths, though, individuals also experience an array of challenges and cognitive disabilities with how this condition affects the brain and their cognitive functioning. Here you'll see a graph of various cognitive domains. 0 is the normative point, and below 0 is an area showing a significant impairment, particularly as we get to minus 0.5, which would be considered about a medium level of severity of an impairment. And what you can see on this graph is whether you're talking about basic cognitive domains like processing speed or verbal learning, or some more social cognitive domains such as emotion perception, being able to pick up and understand emotions in others, and being able to manage emotions. Adults with autism experience significant and profound impairments in their ability, in these cognitive abilities, and their ability to do these types of things. And these challenges are relatively untreated by the current psychotherapeutic interventions that are available, which there are very few, and also by the current pharmacological interventions that are available, which are really largely only approved to treat symptoms of impulsivity and other behavioral symptoms of autism, but not core symptoms of the condition. So we've started thinking more and more that what adults experience and the rate-limiting factors that adults experience with this condition are really cognitive in nature. And if you think about it, being able to study and pay attention in class, being able to keep up with the work line on the job, being able to pick up cues and social information in others and know what to do with that so that you can form relationships. These are all key critical ingredients to a good quality of life in adulthood and to helping an individual succeed in adulthood, regardless of whether they have autism spectrum disorder or not. And if we know that autism affects many of these areas, it should not be at all surprising that without treatment and without interventions that are designed to help address these cognitive challenges, that many adults with this condition would struggle. There's in fact really very little reason for us to leave these cognitive challenges untreated. In fact, this has become a very big area of research in almost all other areas of medicine, psychiatry, and neurology. Here you can see that there's a whole family of interventions that broadly falls under the category of cognitive remediation. And you can kind of think of cognitive remediation as training for your brain. You see my little brain lifting barbells here. And listed up here are papers, review papers of the use of cognitive remediation for all kinds of different conditions, ranging from Alzheimer's disease to Parkinson's disease to traumatic brain injury to schizophrenia, which is where we've done a lot of our work. And almost without exception, there have been exceptions, but almost without exception, This new family of interventions, cognitive remediation, really has shown a benefit in terms of improving brain-related cognitive challenges associated with neuropsychiatric conditions. It's proven to be so successful in so many conditions. There are now reviews of all the studies that have been done and meta-analyses of these studies, in many cases suggesting that they are highly beneficial for individuals with various neurodevelopmental conditions. Our group thought that it would be important, given the promise these interventions have shown in other conditions, to examine their feasibility in adults with autism and to see if these interventions would be effective as they have been in other conditions. The broad idea being that if cognitive challenges, if difficulties paying attention and keeping up at work, reading social cues are the key factors that are limiting adults from succeeding, then their treatment of these problems ought to have significant downstream benefits to areas like social functioning, employment, and other important aspects of adult quality of life. So we embarked on a study of cognitive enhancement therapy, a series of them, which I'm going to tell you about here in a minute. And cognitive enhancement therapy is a cognitive remediation intervention. There are now many of these. There's lots available. This is just one that we use. And this intervention was originally developed for individuals with schizophrenia by Hogarty and colleagues in the early 2000s. It consists of two components. One is a neurocognitive training component, which is on the computer, where individuals work with another partner and complete neurocognitive training exercises in attention, memory, and problem solving for an hour a week. But because we know the challenges in information processing and cognition that adults experience are not limited just to the neurocognitive domain. They're not just limited to basic cognitive processes like attention and memory, but extend to the domain of social cognition. In CET, we have a second component that we implement in the program. It's a small social cognitive group. We feel very strongly that social cognition is best trained, is best learned in a group context where there's lots of social opportunities. And in cognitive enhancement therapy, that's what we try to accomplish with the social cognitive group. This provides individuals with education, training, and practice in such social cognitive abilities as perspective taking, gistfulness, nonverbal communication, and so much more. This is an 18-month program. We also believe very strongly that by the time an individual reaches adulthood and has been living with autism for much of their life, that a prolonged intervention, not an infinite, but a prolonged intervention that really provides sustained support is going to be the most likely to produce meaningful changes and really help adults build a good quality of life as they embark on adulthood. As I said, there are really two components to this program. The first is neurocognitive training, and lots of people do neurocognitive training. There are lots of computer programs available. In cognitive enhancement therapy, the neurocognitive training we provide is a little bit different. It's a bottom-up approach, so it starts with basic cognitive domains and progressively gets more complex, taking the position that lower order cognitive abilities build up to higher order ones. It's also very strategic in nature. During the course of neurocognitive training and cognitive enhancement therapy, you will not just sit in front of a computer and mash a button. You will have a coach in the room with you who will help support your thinking about the best approaches to solving the exercises. This is so important because the goal is not just to train people to do well at the exercises that are in front of them, but it's to help individuals begin to develop the ability to think more strategically about solving problems generally in their life. And as they think about becoming more strategic and as they work on these cognitive exercises and think about the strategies used to solve them, the coach helps generalize that to other problems in their lives and helps them develop a basic and generalized problem-solving strategy that can be used well beyond the computer exercises that are performed during the course of the treatment. In addition, neurocognitive training is performed in pairs. And so another adult with autism is in the room and keeping score while his or her partner is sitting and working on the computer. And these two individuals interact and support each other and trade off in terms of strategies, in terms of time on the computer and exercises in the room. So this process, which is often very sterile and low and sort of solo, often tends to be in cognitive enhancement therapy much more social. And that's very intentional, because a key challenge for adults with autism is in the social domain. And we need to take every opportunity we can to really build and work on that so that we can support individual social development. This is an example of one of the cognitive exercises. It's just a basic memory exercise. You can see that there's a series of shapes at the bottom of the screen, and then there's a series of empty squares at the top of the screen. And when a participant presses the start button, some of these shapes at the bottom of the screen will appear at the top of the screen. And individuals will be asked to remember which shape appeared in which location. And gradually, this is a visual working memory exercise, gradually as individuals become more proficient with remembering the location of two shapes, you build and you remember three shapes, and then you build more and you remember four, and you gradually are able to help develop individuals' cognitive abilities beyond where they initially started. And people are able to see their progress as they do this and proceed through these types of exercises. You can see it's a kind of exercise that's much more akin to a mental workout than a video game per se. These are exercises where you are, in fact, really trying to train certain aspects of the brain and certain cognitive abilities, and they require work and a fair amount of mental effort. We believe all of that is necessary in order to achieve meaningful cognitive improvement with these types of programs. The social cognitive group is small, it's highly structured, and it looks a lot like a class. It contains coaches rather than therapists. That's an important distinction between traditional group therapies and traditional psychotherapies and cognitive enhancement therapy. It's not just a semantic distinction. It's important that individuals learn as much as they are capable of becoming independent. It's important that individuals have the opportunity to struggle and solve problems and do things that they may not have thought they were capable of doing prior to being in the group. And in this way, we coach individuals in the group rather than solve problems for them. Problems are brought to the group, challenges are brought to the group, and we help individuals work through them so that they develop their own problem-solving capacity and their own independent ability to be able to work through the challenges they're experiencing in their own life. There's a 45-session group curriculum. It's highly structured. As I said, it's much like a class, and it covers a lot of content areas. Obviously, the heart of it is various aspects of social cognition, such as perspective taking and acting wisely in social situations and appraising the social context. But it also contains basic information on understanding autism and its characteristics and how to cope with some of the symptoms of autism, as well as more advanced information about how to generalize what's being learned in the group to everyday activities in everyday life. So why did we think this program could be helpful for adults with autism? Well, we had previously been studying it in schizophrenia. As I said, this cognitive enhancement therapy was originally developed by Jerry Hogarty here at the University of Pittsburgh for people with schizophrenia. And although schizophrenia and autism are very, very different conditions, obviously very different conditions in terms of onset, in terms of symptomatology, sometimes in terms of chronicity. But they share a lot of similarities in terms of the social and the cognitive challenges that they experience. And what we found was that when we applied these approaches to people with schizophrenia, when we use cognitive enhancement therapy with people with schizophrenia, that a lot of cognitive domains, many cognitive domains, could be robustly improved well beyond what the medications were able to do for these individuals. And that these cognitive domains, their improvement was really had downstream ripple effects and generalized more than just to our neuropsychological tests or our particular cognitive tests that were involved in the study. They really generalized to broader improvements in social adjustment. You can see the left-hand bars here are cognitive enhancement therapy. They're stacked. These are effects at 1 and 2 years. And then the right-hand bars are enriched supportive therapy, which is a comparison condition that was used in this study. And you can see after 2 years of cognitive enhancement therapy, individuals showed marked improvements in a lot of cognitive domains as well as social adjustment during the course of this treatment, suggesting that it is an approach that could be effective for addressing cognition in another condition that significantly affects the brain. In addition, if you look at the cognitive challenges adults with autism and adults with schizophrenia experience, the similarities are in fact quite striking. Here you'll see healthy individuals in the dark gray, individuals with autism in the medium gray, and individuals with schizophrenia in the light gray across two broad domains, neurocognition and social cognition. And what you can see is that individuals with autism are showing nearly identical levels of impairment in both neurocognitive domains as well as social cognitive domains as individuals with schizophrenia. And in fact, when you look at specific domains of impairment, specific areas of neurocognition and social cognition that are affected by these conditions, they're remarkably similar. The largest area of neurocognitive impairment in schizophrenia has been processing speed in this study, and that's also the largest area of neurocognitive impairment that's been observed in adults with autism. Similar findings have been found for social cognition. And what we can conclude from that is not that everything is the same between autism and schizophrenia, but at least some of the treatment targets of CET, neurocognitive and social cognitive impairment, appear to be as relevant to adults with autism as they are to adults with schizophrenia. Now, the big question is, it sounds like a nice idea, but will it work? Well, like anything, you start small. And you proceed cautiously, especially when you're adapting an intervention from a completely different population. And so we began an initial pilot study funded by the National Institute of Mental Health, which really just looked to see, would this type of approach be acceptable, enjoyable, feasible, and at all minimally effective for adults with autism. So we had 14 adults, a small sample of adults, come into an adapted CET program that had been completely adapted for adults with autism, and we studied them over the course of the 18 months of treatment. And in terms of people voting with their feet, 100% of the individuals remained in the treatment in the first 9 months, and 79, almost 80% of the individuals remained in the treatment for the entire 18 months. Attendance at both neurocognitive and social cognitive training sessions was quite high, over 80% in both regard. And when we asked individuals to tell us how satisfied they were with the treatment, how much did you like being in CET, all of them said that they were mostly satisfied with CET. And the feedback we received from participants in this small study was really very honest, was very helpful, and very instrumental in us further understanding how to adapt this program to benefit adults with autism. But at least in terms of answering our first initial question, it suggests that when you take cognitive enhancement therapy and appropriately adapt it to the adult autism population, that it is something individuals will find that they are satisfied with, that they will attend, and that they will be interested in staying in for a longer period of time. It's important also to note that individuals were not paid to come to treatment for any of these sessions. They did receive research compensation for the assessments that they completed at baseline 9 and 18 months, but individuals only came to treatment because they thought it was helpful, not because they were being paid to come to treatment, which is an important test of the feasibility of any treatment itself. We took some preliminary data from that first study, and you have to take it with a grain of salt. There's not a comparison group, and it's only 14 individuals. What you can see in this graph, though, is baseline, that is prior to treatment, is in white. 9 months mid-treatment is in red, and 18 months treatment completion is in blue. And you see a variety of cognitive domains as well as the domain of social adjustment represented here. And very, very reassuringly and promisingly, these results suggested that as these 14 adults moved through this program, their cognitive scores and abilities, particularly with regard to neurocognition and social cognition, were dramatically improved over the course of treatment. That's similar to what we found in schizophrenia and other populations we've done research with CET on. In addition, These cognitive improvements translated into major improvements in social adjustment, which actually were larger, only slightly, but were larger than every other domain that was affected, suggesting that not only is it possible to address cognitive impairment in adulthood, in adult autism, but it's also possible that addressing cognition in adult autism has major downstream effects on social adjustment and people's ability to function in the community. Now, that can't be the end of the story. That's just the beginning, suggesting that this approach was something that may be useful for adults, something that adults with autism may be interested in engaging in, may be feasible to provide in various clinical settings and centers. But by no means does a study of 14 people and just one group of individuals provide definitive evidence that an intervention is working. So we proceeded with a proper clinical trial of cognitive enhancement therapy, the first clinical trial of its kind, seeking to really rigorously evaluate the efficacy of this approach in adults with ASD. Individuals were included who had autism or autism spectrum disorder. They were between the ages of 16 and 45 years. All individuals had an IQ greater than 80, and so these were individuals without comorbid intellectual disability, and individuals were not allowed to have significant substance use problems and enroll in the trial if they had these within the past 3 months. The trial design was individuals were first screened for eligibility and then randomized to either cognitive enhancement therapy or enriched supportive therapy. This is a second intervention that I'll tell you about in a second. And they were treated for 18 months. Data was taken again at prior to treatment at baseline, at 9, and at 18 months. This is a flow of participants through the trial. What you can see is we screened 170 adults to get a final sample of 54 who were randomized either to the cognitive enhancement therapy or enriched supportive therapy condition. Both of these are very good treatments. In fact, when the study was first funded, it was cognitive enhancement therapy versus usual care was the design. And then we quickly realized that usual care for adults with autism is largely non-existent. And so we took enriched supportive therapy, which we had previously used in individuals with schizophrenia, which is really an emotion management and stress management intervention. It's broadly applicable to lots of conditions, and adapted that also for individuals with ASD. And what you can see, the first thing you want to look at and you want to really evaluate in these types of trials is how many people stayed in. That tells you a lot about the feasibility and the potential efficacy of the interventions under study. And what you can see here is that over the course of treatment, there was a high level of retention, over 70% over the course of 18 months of treatment, both in cognitive enhancement therapy and in the enriched supportive therapy condition. These are some of the characteristics of the 54 participants in the trial. They were all fairly well matched with regard to demographics, although not completely. Their IQ was on average, about average, and similar between the two groups. Interestingly, despite having near normal or near average IQ scores in both groups, individuals' performance on the matrix cognitive battery, which is a neuropsychological test, was well below the 50th percentile normative rank, and suggesting even individuals who have relatively spared intellectual capability also can experience marked and profound cognitive impairments. These are the main effects of cognitive enhancement therapy and from the first trial on both neurocognition and social cognition. You'll see the purple bars are cognitive enhancement therapy. The blue bars are enriched supportive therapy. And what you can see is consistent with our hypotheses. Individuals who were treated with cognitive enhancement therapy showed marked and dramatic, quite large improvements in neurocognitive ability during the course of treatment. Individuals in enriched supportive therapy also demonstrated some improvements in neurocognition, although it was not as much as was observed in cognitive enhancement therapy, suggesting CET is more effective for addressing neurocognitive challenges. In addition, with regard to social cognition, difficulties in picking up social cues and managing emotions and understanding the perspectives of others, you can see individuals with CET again improved dramatically during the course of treatment. Their improvements in social cognition were in fact larger than the improvements observed in neurocognition. At the same time, and what's very interesting, is that individuals in enriched supportive therapy also evidence a really significant and large degree of improvement in social cognition, which was unexpected, and suggests that the results of this trial indicate that we have not one good treatment for adults with autism, but perhaps two, and the second one being in enriched supportive therapy. Because of the efficacy of enriched supportive therapy on social cognition, these two, cognitive enhancement therapy was not significantly better in terms of treating social cognitive impairment compared to enriched supportive therapy. If we look at the individual domains that were most affected with regard to neurocognition and social cognition, what you can see here is that cognitive enhancement therapy effects on neurocognition were largely driven by the left-hand side of this graph, primarily with domains of processing speed and attention vigilance being the major areas of improvement among individuals treated with CET. This is to be expected, given that these are some of the largest areas of impairment, both in autism and in schizophrenia. Other areas of improvement also extended, though, to executive function on the Wisconsin card sorting test, as well as some more modest levels of improvement in verbal learning and visual learning. With regard to social cognition, the picture was much more mixed, as you might expect from the data that I just presented. We see in cognitive enhancement therapy, individuals are excelling in their ability to manage their emotions, but in enriched supportive therapy, individuals are excelling in their ability to understand emotions. Where we really see the biggest changes favoring cognitive enhancement therapy are in emotion perception, as well as in social cognitive behaviors. Behaviors individuals are performing out in the community that suggests that they are taking others' perspectives, that they are tolerant of other social groups and social factors, and then aware of them. Importantly, at the end of treatment, we also asked family members about the degree of social cognitive improvement that their adult children were experienced during the trial. And family members believed that both cognitive enhancement therapy and enriched supportive therapy evidenced significant levels of social cognitive improvement that themselves were not significantly different from each other. Now, a key question with all this work is not just can cognition be improved in adulthood, but if you improve cognition, what will be the beneficial impact to functioning in adults with autism? The hypothesis being that cognitive impairments are rate-limiting factors to successful transition to adulthood and successful functioning in adulthood. And what this graph shows is levels of employment during the course of the treatment trial. The purple lines are cognitive enhancement therapy. The blue lines are enriched supportive therapy. And you can see why EST showed significant improvements in some domains. With regard to employment, cognitive enhancement therapy was clearly the most advantageous. Individuals treated with cognitive enhancement therapy started out with a very large spike in employment by the time of mid-treatment, which was then maintained during the rest of treatment, whereas individuals treated with enriched supportive therapy showed really minimal to no improvements in employment, competitive employment, during the course of treatment, suggesting that approaches that focus on addressing cognitive challenges and cognitive impairments may in fact have significant and very large downstream effects on employment and other important domains of adult functioning. We'll wrap this up to conclude with, we know so much about cognitive remediation in so many other populations. We thought it would be wise to see if it would be beneficial and a beneficial approach to helping adults with autism, and it appears that it is. It appears that it's feasible. It appears that by the time someone is an adult, it is not too late to work on these issues, that cognition still can be improved in adulthood, and that perhaps even by improving the various cognitive challenges individuals experience, that downstream benefits to functioning in such domains as employment may really be realized. And so what we believe is that this is a new therapeutic avenue for supporting adult functioning and adaptive functioning in adults living with autism spectrum disorder. At the same time, we have to be mindful that enriched supportive therapy itself was also very effective, and the benefits of individual support, education, and emotion management may also themselves confer significant benefits to adults living with this condition. As individuals proceeded through this trial, we also took MRIs And we have preliminary data suggesting that as these cognitive changes occur in cognitive enhancement therapy, there are corresponding neuroplastic changes in the brain that also occur, suggesting that even in adults with autism, individuals who've been living with this condition for many, many years, their brains still remain plastic and malleable, and a therapeutic window still exists for interventions to affect the brain in adults with autism and to meaningfully improve cognition in this condition. The work that we're doing is ongoing. The University of Pittsburgh Center for Excellence in Autism Research is focused on building better treatments for adolescents and adults with autism and filling in this evidence base. As we are doing this, we need your help. We are, in fact, focused on 2 treatment studies now at this point. One is a treatment study focused on emotion regulation in adolescents that Dr. Carla Mazewski is running. And for interested individuals, the contact information is available here, as well as the eligibility criteria. The goal of this intervention is to really help individuals be able to better manage their emotions and adaptive behavior, and to really prevent the meltdown and other emotional crises that often happen and are characterized in adolescents with autism. The second study that we are pursuing and continuing to work on is, now that we have an initial trial suggesting the benefits of cognitive enhancement therapy and enriched supportive therapy in adults with autism, we're now engaged in a confirmatory trial with a larger sample. This trial is almost complete. It's over halfway complete at this point, and is recruiting individuals into, again, an 18-month study of cognitive enhancement therapy or enriched supportive therapy. For those individuals who are living in the Pittsburgh area and able to get here on a weekly basis, both of these studies offer opportunities to help contribute to the scientific understanding of how to improve outcomes in adolescents and adults with autism. I'd like to thank my key collaborators, most notably Dr. Nancy Minshew, for all of their support during this work, and also our funders, particularly the Autism Research Institute, for supporting this work and also giving me the opportunity to present it to you today. Thank you so much for your attention.
We have a lot of questions today. The first one is about children. So I know that your focus in this has been on adults. Are you aware of any research that's been done using similar approaches for kids, or would this correlate to ABA, or how do those things connect?
So this is very different than ABA, although I think it's complementary to ABA. We started this work in adults primarily because the population we've adapted it from was adults, and also because adults with autism have very few services available to them. That being said, we do not feel like this work is only limited to adults. We feel like individuals who are in the teenage years and even younger years could benefit from such interventions. We have started some work in this direction with younger individuals, adolescents, and pre-adolescents, but that work is only very preliminary, and we do not know at the moment whether the benefits that we see in adulthood will also be similarly realized in childhood. It's an active focus of our work and direction we're moving in, but at the moment the answers have not been finalized.
Okay. People are asking about how they would obtain CET for their loved ones. So if they live in a community outside of Pittsburgh, are there therapists in the country who are engaging in these therapies, or what would they do?
I really appreciate everybody asking this question, and it's the hardest part about doing this work. This is a very new treatment. It's not available outside of Pittsburgh at the moment, and in order for it to become available outside of Pittsburgh, it needs to show in 2 clinical trials that it's been effective. We're now finishing the second clinical trial, and we hope that the second clinical trial will confirm what the first trial found, that this approach is effective. Once those are done, payers, insurers, and policymakers will now have a sufficient evidence base to move on to support its broader dissemination into the community. This is something that we have already begun in the Commonwealth of Pennsylvania, supported by the Office of Developmental Programs, and we're very eager to do with many other states moving forward as we begin these programs. At the moment, though, implementation is just beginning, and this program is not widely available to individuals outside of a research context.
Okay, are there other universities that are exploring this that you're aware of?
There are other universities that are exploring adult treatment. We are the only group that is exploring the use of cognitive remediation for adult autism. There are some groups that have focused on cognitive remediation in children with autism, and there was a recent study. I'm sorry, I don't remember the university, but I can send it around for to put on associated with this talk for resources for people who are interested. But there was another recent study that was published with children who had autism and also significant intellectual disability that recently showed cognitive remediation may be feasible. So this work is starting a lot of places. I think it's likely the most mature work has been done here at the moment, but there are other groups that are beginning.
Okay, so you mentioned that at least in the second study, the participants all had a normal IQ. I believe I'm saying that correctly. Has there been a study of any individuals who had a lower IQ or who had verbal impairment, or is CET really focused on the what we would call higher functioning individuals?
The CET that we have here has been designed for individuals who have developed sentence language, who are verbal, and who do not have an intellectual disability. But that's not to say that components of this program couldn't be very helpful to individuals that didn't have developed verbal ability and that also experienced significant intellectual disability. And in fact, this work I was just referring to suggests that these approaches, while they clearly seem to show some benefit in higher functioning individuals, can in fact be taken to individuals that have greater level of severity impairment by this condition with some success. We don't know to what degree, we don't know what components. We think some of these components are less translatable to individuals with more severe forms of autism than others. I particularly think that the neurocognitive training component is very translatable, though, and that there's a lot of benefits that could be realized in the more severely affected population with those types of interventions.
Okay. So is the curriculum being developed now? Is that part of the work that you're doing at Pitt, or would that be something that would follow after the research is done?
Yeah, no, that's been developed. That is available. It will be published soon in a supplement to the training manual for schizophrenia, and this is just about to finish its time in research as we close the second trial, and we'll be beginning to disseminate these materials to the broader communities here very shortly. All of this has been implemented by clinical professionals, and it's unclear to me whether or not that's a necessary requirement. I think we do need to think about, so much of people's time is spent with family, and so much of our strongest allies in helping adults are the family members themselves, that we need to begin to think about creative ways to include them and to really help utilize their support with these types of treatments. At the moment, there's not a defined role for family members in CET. Family members are, of course, more than welcome and really have been our biggest supporters in helping make sure individuals come to the treatment program, helping to sustain their motivation for coming, helping to address challenges as they happen in the home, and so on and so forth. But I think that's really an important future direction, is to really think about how can we complement what we're doing here in the clinic with what is going on at home and is what's going on at school and in other aspects of these individuals' lives.
So, a question I've got several people asking about what CET looks like.
Yeah. I mean, I can generally say people's experiences are pretty individual, but when you get into the program, there's really two parts to it. And when both parts are up and running in full swing, individuals usually come in twice a week. They come in for an hour and a half one day of the week, usually to work on neurocognitive training with their partner and to see their coach. And then they come in for an hour and a half a second day of the week to come to the social cognitive group. And so it's usually a 3 or 3.5 hour commitment a week for individuals. And we usually encourage people to do those 3 or 3.5 hours on multiple days rather than on just one day. When individuals come in, they are assigned a primary coach who really helps individualize the treatment to their unique needs and circumstances, but then they also come into a broader team of coaches who help run and facilitate the social cognitive group. And in that regard, they get to know more than just one clinician. They also get to know more than just their partner who is working on computer exercises with them. They get to know a broader group of adults with autism. It's pretty intense. It's not a trivial commitment, and it's a long one. But at least these initial data suggest it's one that may be very worthwhile for many adults with autism.
Right. And one of the domains that you mentioned that was pretty profoundly impacted was employment. Did you want to talk a little bit more about that, about why employment might be one of the areas that's most benefited from this?
We're still discovering a lot of these issues, and we're still really learning a lot about what are the factors that limit things like employment in adults and keep people from being able to get competitive jobs. And of course, there's so many factors. There's stigma, there's social factors, but at least at the core of it, a part of it is a challenge with individuals being able to keep up at work, to get along with others, and to really fit in at work. And what seems to have been addressed in this study is that we helped individuals improve their processing speed ability, the quickness with which they can process information, to the point that they were able to pass a job interview, keep up with the job when they first got it, and ultimately be able to maintain and sustain it. Now that was really very beneficial and clearly showed that treatment of these cognitive challenges can produce meaningful improvements in employment. I'd also like to draw your attention and the audience's attention, though, to the graph, which I've now got back on the screen, which suggests even in the cognitive enhancement therapy group, the maximum level of employment was about 40%. And while that is a clear benefit, it is a statistically significant benefit, it is also cannot be interpreted any other way than a beginning and an area in need of a great deal of improvement, even with cognitive enhancement therapy. What's particularly striking about these data is cognitive enhancement therapy is not an employment intervention. We don't go get people jobs. We're not a supported employment program. It's a cognitive program specifically. And that if you can have this type of effect of employment just with a cognitive approach, imagine how beneficial you can have an effect on people's employment outcomes if you integrate that approach with proper vocational rehabilitation and supported employment interventions.